43,000 people per year are affected by liver disease, leading to such complications as GI tract bleeding, jaundice, malabsorption, delirium, and ascites. The kidneys and liver work together to take everything we eat and drink and turn it into energy and get rid of what we don't need. The kidneys are the water treatment plant, and the liver is the metabolic factory. ESLD, end-stage liver disease, or cirrhosis, occurs when about 90% of the hepatocytes have failed. The liver sits in the upper right quadrant and is the largest internal organ we have, making up 2 to 3 pounds, performing over 400 functions. The liver is fed by the hepatic artery, and filtered blood is returned through the superior and inferior vena cava. Blood travels to the liver through 2 vessels. The hepatic artery comes directly from the heart, and the portal vein comes from the digestive tract, specifically the duodenum. All blood returns through the vena cava back to the right atrium. You cannot typically feel your own or anybody else's liver unless the person is emaciated or the person has hepatomegaly. Hepatomegaly, enlarged liver, develops anytime there is an inflammation of the liver, such as hepatitis or the beginning stages of cirrhosis. The liver is located in the upper right quadrant next to the stomach and above the diaphragm. It is shaped like a boomerang. As part of a physical, the practitioner feels for an enlarged liver. The liver has a unique blood flow situation. Blood travels to the liver directly from the hepatic artery, which branches off of the aorta. The liver also receives nutrient-rich blood from the portal vein. There are hundreds of capillaries that surround the digestive tract. All these capillaries feed into the portal vein, which connects somewhere in the area of the duodenum, collecting all the blood from around the digestive tract and sending that blood to the liver for processing. Many veins, hepatic veins, run from the liver back to the superior and inferior vena cava. Most liver problems occur as a result of poor blood flow through the portal vein into the liver. Imagine the problems that a person could have when blood from the digestive tract can't get into the liver for processing. Functions of the liver. The liver is the largest internal organ and the largest endocrine gland. It also has the largest nutrient storage bank. It stores fat-soluble vitamins A, D, E, and K. Water-soluble vitamins don't get stored and must be replaced every day. The liver contains Kupffer cells, which are a specific kind of phagocyte. They can get rid of dead red blood cells by breaking them down into parts and recycling the parts. Too many dead red cells crowd out the living cells and give the patient a jaundiced appearance. The liver is the chief organ for protein breakdown and usage. The protein we eat is broken down into several components. The useful components are used for tissue and enzyme building. Several waste products result from this process: urea, nitrogen, and creatinine. These waste products are sent to the kidneys to be filtered and excreted. The liver stores about 400 mL of blood that is ready to use in the event of excess bleeding. The liver breaks down estrogen to be excreted. When the liver fails, there is too much estrogen and men take on female characteristics. The liver makes bile from cholesterol that we eat. Bile is essential to break down fat. Fat cannot be broken down by water, only by bile. Bile is sent to the gallbladder for storage and sent to the duodenum via the common bile duct. The liver stores vitamin K, which is the essential precursor of the clotting cascade. Also, the liver breaks down the foods we eat into plasma proteins. One of the plasma proteins is fibrinogen, and another is prothrombin, which make the fibrin plugs. Finally, the liver takes the simple sugars that we eat and stores them in the form of glycogen. We can go many hours without eating, without our brains deteriorating, because when we don't eat sugar, the liver will secrete it into the bloodstream. Some of the anti-hyperglycemic meds work by telling the liver not to put glycogen into the bloodstream. The etiology of liver failure. Alcohol has a direct toxic effect on the liver. With repeated copious amounts of exposure, alcohol will turn the sinuses into fibroid bands. The alcoholic liver will eventually turn hard and fibrotic, making blood flow into the sinuses nearly impossible. The hepatitis virus can cause massive inflammation to the liver and has the same effect as alcohol does. Toxins such as mushrooms, cyclopeptides, or Tylenol, acetaminophen, or tetracycline can cause damage to the liver. Finally, some people present to the hospital with liver damage for no known reason. This is known as cryptogenic. Cryptogenic and idiopathic mean the same thing. The liver with cirrhosis is a hard and fibrotic organ. Blood flow to the liver is impeded when all the sinuses are blocked by scar tissue. Think of trying to get water through the pores of a hard sponge. This picture represents a liver that has irreversible necrosis. The normal architecture of the liver is distorted. There are 4 types of cirrhosis classified by the etiology. Lennox equals alcoholic. Other names include alcoholic hepatitis. Post-necrotic. The patient with hepatitis of any letter, A, B, C, D, or E, or toxins such as mushrooms or drug overdose. Biliary. The patient who has a bile duct problem where bile can't flow through and backs up, causing inflammation. Finally, cardiac. The patient is in liver failure due to right-sided heart failure. Blood backs up and engorges the liver. Hepatitis is one major cause of liver failure, post-necrotic. The 5 major types of acute viral hepatitis vary by mode of transmission, manner of onset, and incubation periods. Hepatitis cases must be reported to the local public health department, which then notifies the Centers for Disease Control and Prevention, the CDC. Hepatitis A. The causative agent of hepatitis A is the hepatitis A virus, HAV. It is a ribonucleic acid, RNA, virus of the enterovirus family. It is a hardy virus and it survives on human hands. The virus is resistant to detergents and acids, but is destroyed by chlorine or bleach, and has a temperature that's greater than 195 degrees Fahrenheit. HAV usually has a mild course, similar to that of a typical flu-like infection, and often goes unrecognized. It's spread via fecal-oral route, by fecal contamination either from person-to-person contact, e.g. oral anal sexual activity, or by consuming contaminated food or water. Common sources of infection include shellfish caught in contaminated water and food contaminated by food handlers who are infected with HAV. The disease is usually not life-threatening, but its course may be more severe in people older than 40 years and those with a pre-existing liver disease, such as hepatitis C. In a small percentage of HIV cases, severe illness with extrahepatic manifestations can occur. That's in table 61.5, but I believe that's in a different text. Advanced age and conditions such as chronic liver disease may cause widespread damage that requires a liver transplant. In some cases, death may occur from HIV. The incidence of hepatitis A is particularly high in non-affluent countries in which sanitation is poor. Children are affected the most, and many of them do not have symptoms. Some adults have Hep A and do not know it. The course is similar to that of a GI illness, and the disease and recovery are usually uneventful. Hepatitis B virus, HBV, is not transmitted like HIV. It is a double-shelled particle containing DNA composed of a core antigen, HBsAg, a surface antigen, HBsAg, and another antigen found within the core, HBeAg, which circulates in the blood. Hepatitis B may be spread through these common modes of transmission: unprotected sexual intercourse with an infected partner, sharing needles, accidental needle sticks or injuries from sharp instruments, primarily in healthcare workers, actually a low incidence, blood transfusions. These were those who were not screened for the virus before 1992. Hemodialysis, and the maternal-fetal route, more common in Asia. The clinical route of hepatitis B may be varied. Symptoms usually occur within 25 to 180 days of exposure and include blood tests, blood tests confirm the disease, and although many people with Hep B have no symptoms, most adults who get Hep B recover and clear the virus from their body and develop immunity. However, a small percentage of people do not develop immunity and become carriers. Hepatitis carriers can infect others even though they are no longer sick and have no obvious signs of hepatitis B. Chronic carriers are at risk for cirrhosis and liver cancer. Because of the high number of newcomers from endemic areas, the incidence of hepatitis B has increased in the United States. The causative virus of hepatitis C, HCV, is an enveloped, single-stranded RNA virus. Transmission is blood to blood. The rate of sexual transmission is very low in a single couple relationship, but increases with multiple sex partners. HCV is spread most commonly by illicit IV drug needle sharing, that's the highest incidence, blood products, blood, or organ transplants received before 1992, needle stick injury with an HCV-contaminated blood. Healthcare workers are at high risk for this. Unsanitary tattoo equipment, and the sharing of intranasal cocaine paraphernalia. The disease is not transmitted by casual contact or by intimate household contact. However, those infected are advised not to share razors, toothbrushes, pierced earrings because of microscopic blood may be on these items. The average incubation is 7 weeks. Acute infection and illness are not common. Most people are completely unaware that they have been infected. They are asymptomatic and not diagnosed until many months to years after the initial exposure, when an abnormality is detected during a routine lab evaluation or when liver problems occur. Unlike hepatitis B, most people infected with hepatitis C do not clear the virus, and a chronic infection develops. Hepatitis C usually does its damage over decades by causing a chronic inflammation in the liver that eventually causes the liver cells to scar. This scarring may progress to cirrhosis. Alcohol use also increases the progression and severity of cirrhosis. Hepatitis C-induced cirrhosis is the leading indication for liver transplantation in the United States. Unfortunately, the newly transplanted liver often becomes reinfected with the virus. What are the complications of cirrhosis? Complications include liver failure, which leads to the worst kind of metabolic problems. Think about what might happen if all the protein you eat cannot be broken down into useful parts. Think about what might happen if blood can't flow into the liver to be cleaned out. And think about what would happen if the bank is depleted of stored sugar and blood. Cirrhosis, or end-stage liver disease, cannot be cured. Even though hepatocytes can still be regenerated, once the 90% mark is hit, the regeneration cannot keep up with the destruction. The complications have already begun, and med providers are simply working to extend the light despite the complications. The only cure would be a liver transplant. To get on the list, the patient must be sober for 6 months. A transplant leads to a new set of complications involving side effects of anti-rejection drugs. The overall goal in treating cirrhosis patients is to minimize the effects of the complications. The goal might be palliative, which would be to keep the patient at his or her highest level of functioning until the end of life. Portal hypertension, which is another complication, is a situation where the blood cannot flow well into the liver tissue. Sometimes the obstruction is caused by sclerosis in the portal vein as well. Sometimes there is a thrombus in the portal vein. With portal hypertension, blood will back up into the portal vein and into the capillaries that surround the digestive tract. Our normal portal vein pressure is about 3 millimeters of mercury, but the patient with portal hypertension might have a pressure as high as 20 millimeters of mercury. Treatment is either medical or procedural. You should look in your book around to look up esophageal varices. This is a picture of an esophageal varice. These are the most dangerous of the complications of end-stage liver disease. Varices are a direct result of portal hypertension. When blood can't get through the liver, it backs up into vessels around the digestive tract. The vessels become engorged, thin-walled, and tortuous. Esophageal varices are like varicose veins in the esophagus. The varices are thin, tortured vessels. These thin, tortuous vessels are at risk for popping, open, and bleeding. Esophageal varices are usually located at the top of the stomach, the fundus, and the bottom of the esophagus. These varices can also happen in the rectum. They're known as hemorrhoids. Patients with varices are frightening to take care of because if they cough too hard or vomit, they can rupture these varices and have massive hematosis, and they can bleed out in just a few minutes. Especially be careful with patients who have an upper respiratory infection and who is coughing. The treatment for varices. Esophageal banding is also done endoscopically in the GI lab. Little bands are put around the bleeding vessels to ligate, that is, to cut off the blood supply to them. Putting rubber bands around the esophageal varices stops the bleeding. In sclerotherapy, an endoscope is passed into the esophagus, followed by a needle with a sclerosing agent, which causes scarring. It is directed into the bleeding vessel. The vessel will shrivel up and there will be normal blood flow. Often the procedure has to be repeated. The trans-jugular intrahepatic portal system shunts, TIPS, is a non-surgical procedure performed in an interventional radiology department. This procedure is used for patients who have not responded to the other modalities for hemorrhage or long-term ascites. If time permits, patients have a Doppler ultrasound to assess the vein anatomy and patency. The patient receives a heavy IV sedation or moderate general anesthesia for this procedure. The radiologist places a large sheath through the jugular vein. A needle is guided through the sheath and pushed into the liver into the portal vein. A balloon enlarges this tract, and a stent keeps it open. Most patients also have an ultrasound Doppler study of the liver after the TIPS procedure to record the blood flow through the shunt. Serious complications of TIPS are not common. Patients are discharged in 1 to 2 days and are followed up with ultrasounds for the first year after the shunt is placed. About 1/3 of them need to be reopened once the first year as an ambulatory care procedure. In an emergency situation, a tube will be inserted into the esophagus and a balloon will be inflated and traction applied. The tube is called a Seng-blake blakemore tube. By inflating the balloons, pressure is immediately applied to the bleeders in both the stomach and the esophagus, and the stomach can also be suctioned. Besides the tamponade of the Seng-blake blakemore, traction can be applied by tugging on the top of the tube. This traction applies pressure to the top of the stomach. There is a manometer to let the care provider know how much pressure is inside the balloons. There are potential problems with the esophageal tamponade tube. If the patient develops respiratory distress, the tube must be removed immediately. Therefore, you need scissors at the bedside for quick removal. Once the tube is removed, the esophageal varices might begin to bleed again, now since the pressure has been removed. Medical treatment for varices includes the following drugs: vasopressin, indorol, and somatostatin. The goal of medical treatment is to decrease the blood flow from the heart to the liver so that more blood can flow from the digestive tract. Vasopressin constricts hepatic arterioles so less blood flow can go from the heart to the liver. The liver will then have less blood flow from the heart and can receive more from the portal vein. Indorol also decreases flow to the liver by slowing the heart rate and decreasing contractility. Somatostatin, also called octreotide, decreases blood flow to the digestive tract. This drug is used to treat severe diarrhea as well as a GI bleed. Ascites is the buildup of fluid, plasma, in the cavity that holds the abdominal organs. This is called the peritoneal cavity. It is caused by two things. First, the portal hypertension causes the fluid to shift out of the vessels. There is so much pressure in the vessels around the digestive tract that fluid is pushed right out. That's hydrostatic pressure. Second, since protein cannot be broken down, the intravascular water magnet is gone, that is, albumin, and there is nothing to hold the fluid in the vessels. This is a decrease in oncotic pressure. Ascites is like edema of the abdomen. There are two problems with having ascites. One is that the patient can get very uncomfortable and dyspneic from the pressure lifting the diaphragm, and the other is that fluid is allowed to leak out of the bloodstream and lead to a decrease in cardiac output. When a patient becomes too uncomfortable, a paracentesis is done. The major side effect of paracentesis is puncture of an internal organ and severe hypotension from fluid shifting out of the intravascular space and into the peritoneal cavity. Note that the sitting man has blood pressure cuff. In paracentesis, the patient sits at the side of the bed and a numbing medication is given. The patient does not have to be NPO, but they must void first so the bladder won't be distended. 2, 3, or 4 of these 1-liter jugs will be filled with the peritoneal fluid. You want that fluid to be clear. The fluid is usually sent to the lab to look for protein levels in organisms. Peritonitis can be ruled out through the analysis of the peritoneal fluid. The patient with a paracentesis needs To have the procedure explained and you need to answer the patient's questions. You need to obtain their vital signs, including weight. You must ask the patient to void prior to the procedure to prevent injury to the bladder. Position the patient in bed with the head of the bed elevated. Monitor vital signs per protocol or the physician's request. Measure the drainage and record it accurately. Describe the collected fluid. Label and send the fluid to the lab for analysis. Document in the patient's record that the specimens were sent. After the physician removes the catheter, apply a dressing to the site and assess for leakage. Maintain a bed rest per protocol. Weigh the patient after the paracentesis. Document in the patient's record both before and after paracentesis. Portal systemic encephalopathy, also called hepatic encephalopathy or coma, is caused by an inability of the liver cells to metabolize protein. When we eat protein, it normally gets broken into parts in the duodenum and then sent down to the liver for processing. Many useless byproducts are formed during the breakdown. Ammonia is one of these products. With a failing liver, ammonia cannot be broken down to be sent to the kidneys for excretion. Ammonia collects in the brain tissue. The patient becomes disoriented like someone who is drunk. The disorientation progresses to a stupor and finally a coma. The patient will develop a sign called ascites, which is also called liver flap. When the patient is asked to extend the arm and hand, uncontrollable flapping at the wrists occurs. The patient will be admitted with PSC and given lactulose 30 to 60 mL to get the ammonia out of the bloodstream and into the digestive tract to be excreted. You do not want the patient to have diarrhea, but you do want the patient to have 3 to 5 loose stools per day. The medical providers will ask you to hold the lactulose for more than 5 stools per day. Lactulose is thick and sticky. Some patients can drink it straight, but many will want it mixed in some juice. Patients with PSC should have low protein diet since protein breakdown leads to more ammonia in the bloodstream. Blood breakdown leads to increased protein levels as well. Also, excess bacteria in the digestive tract will lead to more protein as well as ammonia. The patient might be treated with neomycin, which can be given either orally or via enema. The patient with end-stage liver disease will have prolonged clotting times. They will typically have INRs of 2 to 3. Decreased clotting ability is quite dangerous, especially when combined with esophageal varices. Coagulation defects happen due to no storage of vitamin K and the inability to synthesize the plasma proteins from food that is eaten. Prothrombin, fibrinogen, and vitamin K are all deficient. These patients are on bleeding precautions, and we treat them with vitamin K injections and maybe fresh frozen plasma to replace the plasma proteins. There are 3 types of jaundice named for the etiology. With liver failure, the patient either has hepatocellular or obstructive jaundice. In hepatocellular liver cell jaundice, the liver is unable to do the job of breaking up dead red blood cells into their components, heme and bilirubin, and joining or conjugating the bilirubin into an excretable form. The hepatic sinuses and ducts are fibrotic, and bile cannot flow through into the duodenum. These 2 problems lead to yellow sclera, icterus, and yellow, dry, itchy skin. This is a picture of caput medusae. Caput medusae are varices that appear under the skin of the abdomen. Caput medusae is brought about by portal hypertension, leading to the backup of blood into the capillaries surrounding the digestive tract. Male patients build up estrogen since the liver is unable to break down the hormone and excrete it. Some men will have female characteristics and breasts, as well as high-pitched voices. As the liver fails, eventually the kidneys will fail too. The circulating blood of a patient with the SLD is full of substances that are harmful to the renal tubules, leading to intrarenal failure. X-ray can be used to look for hepatomegaly, but CT is more specific. Ultrasound can also detect the size of liver and the progress of the disease. The patient might have a percutaneous transhepatic cholangiogram, an endoscopic retrograde cholangiopancreatography, an EGD, or a liver biopsy. In a PTC, dye is injected right into the biliary ducts, and then X-rays are taken to see how the dye flows. The X-ray might show areas where dye can't flow. In liver biopsies, a sample of the liver is taken by sticking a needle directly into the liver. After the procedure, the patient should lie flat on their right side with a pillow under that side to apply pressure to the area. Before an invasive procedure like this, involving a needle, the patient's PT, INR, and INR should be checked to see if they need vitamin K or plasma. An EGD is used to look for esophageal varices. While the EGD is underway, sclerotherapy or banding can be performed.